Hi, I'm Dr. Koratala from Medical College of Wisconsin, USA. In this lecture, I'll give a brief overview of how to use point-of-care ultrasonography in the management of acute kidney injury. I have nothing to disclose. So first of all, what is POCUS? Point-of-care ultrasonography, or POCUS, is the clinician-performed ultrasonography at the bedside to answer focused questions. For example, the questions that we have after a traditional history and physical examination. And answering these questions will either give you the diagnosis or narrow the differential diagnosis, or you can use point of care ultrasonography to guide a procedure. And it should not be viewed as a different imaging modality. POCUS is a component of physical examination. It's in addition to inspection, palpation, percussion, and auscultation, insonation or ultrasonography is one of the components of bedside examination. And because the ultrasound devices are becoming smaller and smaller, they fit in your coat pocket. You can use them analogous to your stethoscope. I know you had a lecture on basics of ultrasonography. So I'll just give two important pointers for you to be able to easily interpret the images that I show. First of all, image orientation. When you look at any ultrasound image, the structures that are closer to the probe are on the top of the image, and the structures that are away from the probe are displayed at the bottom of the image. And there is always a marker, the screen orientation marker, which is usually a letter or a symbol that denotes the ultrasound manufacturer, which corresponds to a similar marker on the transducer or the probe. So if you're holding the probe with the probe marker pointing towards patient's head, this part of the image becomes towards patient's head, and this part is towards patient's feet. So for example, in the kidney image, if you see a cyst here, you know this is upper pole of the kidney because you are pointing your probe marker towards patient's head. And how do various structures appear on ultrasound screen? So you call a structure hyperechoic or making more echoes when it is brighter than the surrounding area. That means it's reflecting almost all the ultrasound waves that you are hitting it with. Examples include stones, bones, fibrous structures such as diaphragm, and air. Air is important to note because we are so much used to seeing air as a black structure on plain radiographs and CT scans. On ultrasound, air appears white because it reflects the waves. And bones and stones, typically they give a shadow behind them. It's like you cast a shadow behind you when you're in pathway of the light. Similarly, when you're reflecting all the sound waves, you have a shadow behind you. And structures that are excellent transmitters of sound waves are called anechoic structures, and they appear black on ultrasound screen. That means they are not making any echoes. Examples include blood, urine, serous fluid. That's why all the blood vessels appear black on ultrasound. Hydronephrosis appears black, and serous fluid in the cyst appears black. And soft tissues appear in different shades of gray depending upon what substructures they have inside them. For example, liver, kidney, all these things are in shades of gray. So how do we use ultrasound in acute kidney injury? We know that acute kidney injury has three main causes: obstructive, hemodynamic, and intrinsic renal. So obstructive causes are easy to rule out with ultrasound. So you look for hydronephrosis, whether it's present or not, and if it's there, if there is any cause for hydronephrosis, such as a stone, or if there is a bladder outlet obstruction. And intrinsic renal, it can be caused due to tubular injury or tubulointerstitial inflammation and so on. And ultrasound is less useful here, but the utility of ultrasound here is that it can be used to differentiate acute kidney injury versus chronic kidney disease when you are not sure about the baseline kidney function. And hemodynamic AKI could be because of true volume depletion or insufficient forward flow, such as in heart failure, or venous congestion, also in heart failure. Those things you should be able to delineate using ultrasound. And this is how hydronephrosis appears. So on the left-hand side is a normal kidney. So you're looking at the right kidney, for example, through the liver. So liver is on top of the image, and you have a bean-shaped kidney here. And you have kidney parenchyma, which is divided into outer cortex and inner medullary pyramids. Medullary pyramids are usually black in color or anechoic. And You may or may not always see them depending on the image quality. And in the middle of the kidney, there should be collecting system. But in undilated state, in normal state, collecting system is not visible. It's encased by sinus fat, which is bright in color. So in middle of the kidney, all of this is sinus fat. But when you have hydronephrosis, it appears as a anechoic or black branching structure. So the obstruction is usually somewhere distal, and there is back pressure pushing urine back into the kidney. And that's when it disperses all the sinus fat, and you see this black collecting system, as opposed to just seeing the fat. Here is another example of hydronephrosis where you see black or anechoic collecting system, and you see some bright structure here. So this is the stone, and it's casting a shadow. You call this acoustic shadowing. Acoustic is something related to sound. So here is the illustrated image. So here is the hydronephrosis, this is the stone, and this is the shadow. And when you're dealing with transplanted kidney, beware that some degree of pelvic calyceal dilatation or mild or minimal hydronephrosis might be acceptable. It's always good to compare with the prior imaging if available before blaming acute kidney injury on obstruction. That's because transplanted kidneys have decreased ureteral tone and a smaller ureteral size. So some degree of reflux is common. And in transplanted kidney particularly, you can have perinephric collections that can cause pressure effect on the kidney and acute kidney injury. So for example, here is a kidney, and surrounding all this, you have the septated fluid, and we drained it and found it to be a lymphocyte. And here is another example. This black anechoic structure here is seroma. This is the transverse section of the kidney. And this seroma is pushing on the ureter, causing the ureter to dilate, and the urine is going back into the kidney, causing mild hydronephrosis. So you can have perinephric collections themselves causing AKI, or these collections can lead to hydronephrosis. So ultrasound of the urinary system is not complete unless you look at the urinary bladder. In normal state, when urinary bladder is distended with urine, it appears black or anechoic. So this is the transverse section, and this is the sagittal view of the bladder. And the shape of the bladder can vary depending upon how much urine it has, but in general, in transverse view, it's more or less rectangular. And in the sagittal view, it could be more triangular in shape. And when you have a Foley catheter to drain the bladder, and the bladder is in its non-distended state, this is how it appears. So basically what you see is a ball-like structure filled with fluid in the middle, which is the Foley balloon. And bladder is decompressed around it, and you do not see a black bladder. But presence of Foley catheter does not mean the patient does not have obstruction. For example, in this case, the patient has a Foley catheter, but still you are able to see all this urine-filled urinary bladder. So that means this Foley catheter is obstructed, and you need to flush the catheter. And sometimes you might see enlarged prostate compressing the bladder, which could be the source of obstruction. Similarly, you can see tumors going into the bladder and causing obstruction. And here is a nice example of urinary bladder stone. So this rectangular thing is the urinary bladder, this anechoic thing. And here is a hyperechoic or bright structure, which is a big bladder stone followed by a acoustic shadow. Here is the illustrated picture. So this is all the urinary bladder. This is the stone followed by a shadow. So that's about obstructive causes. And when it comes to intrinsic renal causes, you're primarily looking at the size and echogenicity of the kidney. And when I say echogenicity, it's relative echogenicity. That is, you're comparing the brightness of the kidney cortex to surrounding liver in case of right kidney, or the spleen in case of left kidney. Normally, the kidney length is about 10 to 12 centimeters and varies with the height of the individual. And when you say cortical thickness, it's from outside of the kidney to the base of the medullary pyramid. It's usually about 0.7 to 1.1 centimeters. I remember it as roughly about 1 centimeter. And parenchymal thickness is from outside of the kidney to tip of the medullary pyramid. It's approximately twice as much as cortical thickness, approximately 1.4 to 2 centimeters. And remember, I said like it's not always that you see nice, clear medullary pyramids. That's when parenchymal thickness helps. You just go from outside of the kidney till you see the sinus fat. In chronic kidney disease, usually you have increased cortical echogenicity and decreased kidney size, or both length and thickness. But increased cortical echogenicity is not specific. For example, this image was obtained from a patient with acute lupus nephritis. And you can see that the kidney size is well preserved. The thickness is 2 centimeters and the length is 12 centimeters. But the cortical echogenicity, that means how bright the cortex is appearing compared to this liver here, is significantly increased. It could be because of interstitial inflammation in a case of lupus nephritis like this, or any kind of glomerulonephritis, or you can have this kind of picture even in acute interstitial nephritis due to inflammatory infiltrate, or acute tubular necrosis when you have proteinaceous substances. So that I'm just saying it's not specific. Don't rely on cortical echogenicity alone and look at the kidney size. And here is an example of chronic kidney disease where you have increased cortical echogenicity, but also decreased kidney length and decreased parenchymal thickness. So that finishes obstructive causes and intrinsic renal causes. Now the hemodynamic causes. So hemodynamic causes are important because if you ignore them, the injury will further progress and lead towards acute tubular necrosis. To assess a person's hemodynamics, you need to evaluate three things: the pump itself, that is focused cardiac ultrasound and see how the heart is working; pipes, that is look at the inferior vena cava and get an idea of the right atrial pressure; and if you have the Doppler capability, look at the hepatic, portal, and renal veins and see how the blood is flowing; and leaks, that is look at lung ultrasound and abdominal ultrasound to look for free fluid. And if you are proficient in advanced point of care ultrasonography, that is in using Doppler, you can do a lot more stuff. For example, you can assess the whole hemodynamic circuit flows, how the blood is flowing at different points in the circuit, and get an idea of where the resistance is and how you can manage those. For example, here you can look at the left ventricular outflow tract Doppler and get an idea of stroke volume. That is then an idea of the forward flow. And you go back and look at the mitral flow and pulmonary vein flow, get an idea of the left ventricular filling pressure. So that is how is the ventricle relaxing. And then you go further in the hemodynamic circuit and look at the blood flow in through the tricuspid valve and right ventricular outflow tract. That gives an idea of the pulmonary resistance. And then you go back and look at the inferior vena cava and all these venous Dopplers. They give an idea of the venous congestion in a case of congestive heart failure. And also you look at the lung ultrasound and abdominal ultrasound as an adjunct to this. So briefly, how does lung ultrasound look like? So normally you cannot ultrasound lung as a tissue because lung is a air-filled structure and air is reflective to ultrasound. So you see lung tissue only when you have consolidation. So in normal air-filled lung appears like this, like you just interpret artifacts. So only thing that you see is the pleural line, which appears as a white shimmering line. That shimmer or that shining corresponds to pleural sliding. And you have this reverberation artifact where you see multiple reflections of the pleural line equidistantly. And these are rib shadows in between. So you place the probe perpendicular to the chest wall and you see all these reflections of the pleural line. These horizontal lines are called A lines. A lines are seen when there is air in the lung. And when you have thickening interlobular septae or interlobular septae are distended with fluid, you see these vertical lines instead of horizontal lines. So here is the pleural line. It does shimmer, but instead of seeing horizontal lines, you see vertical lines arising from the pleural line and going till the end of the screen. And here is another example. Here is a pleural line. Here are the vertical artifacts when you have fluid in the lung or pulmonary congestion or pulmonary edema. These are called B lines. And the severe is the extravascular lung water, or severe is the pulmonary edema, the more number of B lines you have. So you can count these lines also. And this is how a pleural effusion appears like. So remember we said all the clear fluids appear black on ultrasound or anechoic. So here you're looking at the dependent portion of the lung from the lateral aspect, and you see all the black thing, that is pleural effusion. And here you see something like a fish tail or whale tail, that is the atelectatic lung surrounded by effusion. And coming to inferior vena cava. Inferior vena cava is essentially a big blood vessel that goes to the right atrium of the heart. And here in this image, you can see that there is hepatic vein that's joining the inferior vena cava, and inferior vena cava is going into the beating structure, that is right atrium or the heart. It's important to note these features, that is hepatic vein, and make sure that inferior vena cava is going into the right atrium, because you can confuse aorta with inferior vena cava because you find them both in the subxiphoid view. And inferior vena cava is nothing but a tubular structure or a pipe that goes into the right atrium. So it accurately reflects pressure inside the right atrium. So what does right atrial pressure tell you? It's essentially tells you how much resistance the heart is offering to the blood flow. If the IVC is small and collapsible, probably you have less right atrial pressure. If the IVC is big and non-collapsible, that means it's plethoric, the right atrial pressure is high. And the last component is the focused cardiac ultrasound, or the heart. And you can view the heart from multiple planes, and you can slice it in multiple angle. So one is parasternal view. That means you put your probe in the adjacent to the sternum on the left side of the chest, and you look at the heart in its long axis. That becomes parasternal long axis. Or you can slice the heart in its short axis. That's parasternal short axis. Or you can place the probe in the where you feel the apical impulse and slice the heart in its coronal plane. That gives you the apical four-chamber view. And if you look at the heart from the subxiphoid window, then you get the subxiphoid four-chamber view, which is very similar to apical four-chamber, but slightly tilted. And you can compare these heart views as if you are slicing a bread roll. For example, if you are slicing the bread roll longitudinally, you get long axis view, and transversely, you get the short axis view. And if you are slicing bread roll in half, then you get the apical four-chamber view, that is the coronal plane. And how do we assess LV systolic function using, say, for example, parasternal long axis view? So in parasternal long axis view, the structure that is close to the probe is right ventricular outflow tract. And here is the left ventricle, here is the left atrium. So here is the LV, RVOT, and the left atrium with the mitral valve. In normal state, the left ventricular walls come close to each other by at least 25%. And also, because the left ventricle is emptying nicely, during diastole, the mitral valve will open completely so that more blood goes from left atrium to left ventricle. But as the function of the LV decreases, the squeeze becomes lesser and lesser, and the mitral valve opening is not so much. And here is the moderately reduced LV systolic function, and here is severely reduced LV systolic function. The LV walls are barely coming close to each other, and the mitral valve is not really opening much. And the more hearts you see, the more experience you get in terms of assessing systolic function. And using focused cardiac ultrasound, you can also get a good idea of if the patient has pericardial effusion. For example, in this parasternal long axis view, here is the left ventricle, here is the right ventricular outflow tract. You see a black anechoic structure here that is surrounding the heart, that is the pericardial effusion. And what is this thing on the right here? So this is the parasternal short axis view. That means this is the left ventricle and this is the right ventricle. And instead of being nice and round, the left ventricle appears like a D. What's happening here? This patient has a lot of fluid. So all the fluid that you give initially goes to the right ventricle, right? So, and if you have more resistance to the flow in the lung because of pulmonary hypertension or maybe pulmonary embolism or whatever the cause, so the interventricular septum is getting flat and pushing on the left ventricle. So in this case, if you give more and more water to the patient, or there is more fluids, the left ventricular outflow is reduced, or the stroke volume is reduced, and the patient is going into shock. So not all hypotensive patients are hypovolemic. So here is like when you put all these things together, this patient is most likely volume depleted because the heart seems to be hyperdynamic. The systolic function is probably more than normal, and it's trying to increase the stroke volume. And the lungs are clear, that is, you are seeing A lines, and the inferior vena cava is small and collapsible. And you can see similar picture when you have hyperdynamic heart in septic shock because of the vasodilatation. That's why doing advanced POCUS helps when you can actually determine the stroke volume. In this hyperdynamic heart, if the stroke volume is low, that's volume depletion. And if the stroke volume is very high, that indicates distributive shock. And this is a case of diuretic deficiency, or in other words, a case of severe heart failure, where you see that the heart is barely functioning, the mitral valve is not really opening, the walls are not squeezing, and lungs are filled with water. So you can see this pleural line and all these vertical B lines, and the IVC is big and plethoric, that is non-collapsible. So this patient would benefit from diuretic therapy. So that's a brief overview, and you can follow me on Twitter at nephropy, or go to nephropocus.com for more POCUS scenarios. Thank you.